Good afternoon. I'm Lorna Lucas, Assistant Director of Provider Education for the Association of Community Cancer Centers. I'm eager to introduce Dr. Sarah Hudson-DiSalle, our expert presenter for the 6th eCourse of the series hosted by the Institute for Clinical Immuno-Oncology, or ICLIO, who will discuss the evolving role of the pharmacy manager and the real-world issues that impact IO agent reimbursement. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by IO and includes other vital resources such as newsletters, papers, scholars program, and a national conference, which we have scheduled for September 30th in Philadelphia. So I hope you'll visit www.accc-iclio.org to browse all of our offerings. So for today's eCourse, I'm pleased to introduce Dr. Sarah Hudson-DiSalle, Pharmacy Manager in the Medication Assistance Program and Reimbursement Services at the Wexner Medical Center and James Cancer Hospital at Ohio State University, where she's responsible for overseeing, coordinating, and advocating for the award-winning Medication Assistance Program for inpatients and outpatients who cannot afford their medications. She's been successful in the development of services aimed at improving access to medications across the OSU system, as well as maximizing off-label medication reimbursement. Dr. Hudson-DiSalle is also responsible for overseeing reimbursement authorization for off-label medication use, high-dollar therapy, infused medication, and medication denials in the James. There's also an active in pharmacy organizations at a local, state, and national level. She serves on the board of the Charitable Pharmacy of Central Ohio, serves on the legislative committees of the Ohio Society of Health System Pharmacists, and on the Health Policy Committee of the Hematology Oncology Pharmacists Association, HOPA. Now for a few housekeeping notes for today's webinar, please feel free to submit any questions you have to our presenter by typing in the questions in the box on your dashboard. We will pose all questions to our presenter at the end of the presentation. This webinar will be archived and available on the ICLIO website by the end of the week, which again is accc-iclio.org. So now I'll send it over to Sarah to kick off the webinar.
Good morning or good afternoon for those folks that are here on the East Coast. Thank you for joining today. I have a lot of material, so we are going to get started here. Next, please. I do intend to talk about some off-label indications for the products during this activity. Next. Our objectives for today's talk will be to discuss approved and unapproved uses of immuno-oncology agents, review current experiences with payer reimbursement of IO agents, explain the importance of understanding payer policies and reimbursements for IO agents and proactively interacting with payers, and describe resources that are necessary to avoid denials and ensure payments of those IO agents. So we got big topics to go today. So to set the stage for my presentation, I thought about sharing the information of my role and my team's role would be helpful. At my institution, all of our drug approvals, both on and off-label, and denials are handled within the pharmacy department by my team. The individuals that are responsible for this are called reimbursement specialists. I also oversee our medication assistants, but for the purposes of this presentation, I'll be focusing on my role in those roles of the reimbursement specialist related to coverage and payments of the IO agents. Next. The current IO agents that are on the marketplace, if you're not aware, of pembrolizumab, nivolumab, and the new kid on the block, idezolizumab. So next. Just really quickly, I just want to go through the FDA approved uses for pembrolizumab. Next. Nivolumab, and then also the new kid on the block next, the idezolizumab, the Tecentriq from Genentech. Next. We also see, I wanted to put in some of the non-FDA approved uses that we do see that come through the James. This is not intended to be an inclusive list, but there's some of the most recent usage that we have seen, some of the uses that we've seen historically over the last year and a half have been now that some of these are FDA approved as more literature has come out. Next. the IO agents have also made a unique surgence with patients who have researched their options, therapies, and sometimes it's a product of the marketing. In these recent TV ads, the highlighted stories of famous presidents and support groups have really increased the demand. But the other thing that they've also done, they've really messaged hope and optimism where previously there's been few therapies existed. I will say we have seen at the James many requests for first-line therapy from both our patients and our providers increasing because they feel like it's a better fit for their patient rather than exposing them to other therapies initially. Next. So from the beginning of when pembrolizumab and nivolumab first came on the market, my director and I met with our CFO and talked to him about how these agents were going to increase and the train was going to leave the station, and that there was going to be a variance in our budget line. And as you can kind of see from this slide is our numbers of dispenses at the James. We really did, and so it's one of the things that I like numbers. These are one of the things I think a picture's worth 1,000 words. So this is kind of how we've seen this through from the inception in November up until the last in the end of June of 2016. Next. And likewise, we are also seeing the number of patients include. We actually only have a couple patients that are getting Tecentriq, so I didn't include them in this just because of the data just isn't there for us yet. Next. In this upcoming section, I'd like to review the current experiences that we have experienced with the IO agents and the reimbursement payers. Next. I'd like to begin with our federal payers for original Medicare specifically, and some of our state plans, and I should say some Medicaid plans as well. For these plans, you can't ask for permission ahead of time, so you need to go to the Medicare administrative contractors that are in your region, and there are 14 that are out there, but they typically have at least one local coverage decision that is published or some type of an article that gives some type of guidance around payment and medical necessity based on diagnosis. The MAC that's in our area in Region 5 is CGS, and actually within 6 weeks of Tecentriq being released, there is also now an LCD that is affiliated for the usage of that. So we have all 3 agents in Region 6 that have that. To date, there is no national coverage determination, and I really hope that there won't be a national coverage determination for these medications. But the crystal ball, who knows what will happen. Next. In contrast, our commercial payers probably have a little bit more guidelines than what the LCDs that are in place. And I'm going to lump the Medicare Advantage plans just because many times they use some of the tools that the commercial carriers that sponsor these plans that fall into this. So probably the biggest guideline that the commercial payers will put forward are in the form of clinical policy guidelines and various pathways. I've listed a couple examples, but typically those clinical policies will show what they consider medically necessary and what the kind of the framework is for coverage. Many times we are starting to see that clinical policies include things that are outside of the FDA label or things that have gone into the study, or maybe it was a small part of the study. And that can include prior therapies, combined therapies, but probably another big example would be like Anthem actually has in their clinical policy for nivolumab. Actually, you have to have an ECOG score of 0 to 2 to be met before you can be reimbursed for the medication. So that's making sure that your payers or your clinical folks understand that they need to make sure that they're looking at performance status when those patients come in. Next. There's a few restrictions that the commercial payers have put in on top of those clinical policy or payer pathways. One of the ways that they've done this is a maximum dosage unit regardless of weight. So these are basically the max amount of they have a cap on these dosing limits. So sometimes they'll be called frequency edit, sometimes that they'll have this as a max allowable unit. Different payers will call them different things. We have also run into a very unique and frustrating authorization mechanism that some of our payers that are using, that we only currently have one payer that is using, but I know that across the country there are some other payers that do use this. It's an authorization in an NDC unit versus having it in your typical HCPCS milligram billing unit. They give that in the conversion into an NDC unit that will equate to a milligram unit per infusion. Now, they may give you a total number of units for the entire length of the therapy, and it's up to you to make sure that you're doing the math to figure out, that crosswalk in between the authorization. So an example would be like 9 milligrams of pembrolizumab, or 9 NDC units for pembrolizumab equals 90 milligrams of pembrolizumab. So you have to make sure you monitor it for underpayment. You have to make sure that there's no errors in that, and then following up with the plans. Next slide, please. I wish I could report that authorizations, once they're in place, they're always accurate. You need to make sure that those authorizations, when given to you by the payers, actually match the date range that has been provided. So if you get an authorization for a 6-month time frame, make sure that there's enough infusions authorized for that time frame that is there, because just because the time frame will link that, if it's over a 6 or a 9 month period and you don't have 6 or 9 months of authorizations included, you will get denials after the number of infusions have exhausted. So let's say they give you 6 infusions, but they give you a 9-month period. After that 6 infusions, you start to see denials that will occur. So making sure that those dates on authorization match are important. And I wish I could also say that that you don't see retrospective denials for like predeterminations or even authorizations of saying that the authorization isn't in place. It's a game the payers do play, that you have to hold them accountable. And so it's very important to make sure that you're on top of that on a timely fashion. Next slide, please. This is probably another hot topic of billing for waste. Making sure that you are adequately billing for waste and using the proper modifier, the JW modifier. Basically, the JW modifier will indicate the amount of waste of the volume that's represented. All of the IO agents are single-use vials, so we don't have to worry about, inappropriately using a multi-dose vial for billing for waste. But if you have, especially if you're a smaller institution or you only have a couple of patients that are in that day and you do have waste, you can bill payers as long as they accept that waste amount for that. Now, not all payers will accept for waste, so making sure that you have a set practice that you are doing that, as well as if you're billing for Medicare, original Medicare for waste and any of the Medicare Advantage plans, making sure that you're documenting why you're billing for waste. You saying that it's provided only in a single dose vial and this is the remaining amount is sufficient for that. But that is required on claims for Medicare as far as for audit purposes on January 1 of 2017. Next. I'd like to take this opportunity to show you the organization and our organization at the James, how we're able to successfully leverage the resources that we have here to have good reimbursement for both our IO and other high dollar agents. Next. Kind of back to that slide again, that basically shows that our reimbursement specialists, I have 6. 3 of them work basically on my regular infusion. I have 2 that work on high dollar and off-label indications, and then I have one FTE that focuses on denial management. We do have some cross areas that sometimes, as far as so my denial person doesn't get too burned out, we do fluctuate of making sure that they're up to date. Next. Now, I like to say our first line of offense is our reimbursement specialist. They are, each one of those qualifications, when they come in, each one of those employees, they have some type of clinical background, ideally with some oncology experience, but lots of times you can't teach that tenacity that you really need with the reimbursement specialist. They need to have that fundamental understanding of payer terminology, requirements, how do they move and shake in between each payer, and what they'll be able to leverage and do that. And I talk about kind of the qualities of, for those folks, tenacity is a big one with that they're self-sufficient, they can multitask, they're motivated, and a lot of these, and probably 4 out of the 6 of mine have been bedside nurses before. They've taken care of patients. They want to advocate, and they feel like that they're doing a great job for their patient on kind of the back end, and they're kind of behind the scenes and doing what they need to get done. But they have incredible organization skills. They can prioritize of what needs to be done, and we have some tools that kind of help them out electronically as well doing that. Next. Kind of one of the things that I've listed some of the responsibilities for the reimbursement folks of what they're responsible to do. Think about if your reimbursement specialists are going to be the authors for your patient's therapy stories. They're going to gather all the information, and they need to have a strong understanding of their background of their information. So any good author is going to make sure that they understand that their focus of what we're talking about. Are we talking about our renal cell, our clear cell patient? Are we talking about our non-small cell lung cancer patient, the staging, where that fits in therapy, the literature that is there, what is clinically appropriate, what have they not done, what level of the tumor type that we're talking. Next. They become kind of your first line of defense against those denials. So if they write a good story and they get the authorization, hopefully that's going to prevent denials that kind of come back to us. So the flip side of what happens is if we do have denials, they're the best persons that they know these cases, and they're going to be able to write good appeal letters. They actually help to they work with me to help to identify trends. We also then provide education back to our clinical staff, as well as our managed care payers, to help to reduce denial. So if we're seeing a trend, we actually will say, hey, can we have a conversation and help? We work with our managed care team to set up calls and say, we're seeing this. We don't agree with this. This is what how do we come to a solution for this? Is it something we're doing wrong? Is it something that the payer is inadvertently doing wrong, and kind of come to a solution for that. And then at times I feel like we kind of QA for our medical information folks. We have some contact folks that will say, is this really coded this way, or can you look at this case and make sure that maybe it just needs a new code and it goes back to the biller to get fixed. So sometimes that's one of the things of creating that relationship with MIM. They're good right-hand folks. Next. Moving back to kind of our offensive tactics, I think one of the best tool, and it's an essential tool for any IO agent as well as high dollar agent, any infused agents, is pre-certification. And so in order to direct you need to be able to direct those prior authorizations, and whether you're a really big center or a really small practice, you need to make sure that you're getting every single infusion coming through to your staff, and so they can work those claims appropriately. How do you figure out medical eligibility? What type of documents do you need to have? Making sure that you're looking at various payers, and if they say that they don't do a pre-cert, especially for the high dollar medication, medication, ask for a complimentary pre-cert. And just making sure that somebody at the payers is putting eyes on this and saying, oh, this is, you're out of network for this, or you're, this is, yes, we need you to fill out this form, that maybe that the person, when you called and they said authorization not needed, and the drug, that charge is going to come through for $25,000, we want to make sure that it's going to be covered. Next. These are some of the additional tools for success that what we've been able to do with our frontline staff. So our specialty practice pharmacists, our infusion pharmacists, our nurse practitioners, our providers, showing, they're familiar with any type of evidence-based guidelines, as possibly like compendias, any clinical policies from payers that may deviate from the practice that they're working with. And so of coming up with, okay, we know that we'd like to start this patient on this therapy. We know these are the steps. What do I need to do to make sure that the patient doesn't come back with a large bill, or the hospital doesn't come back with a large bill? And one of the things for your staff that are your frontline staff that are sending these authorizations, making sure that they're complete and legible, especially if they have to fill out a form. Nobody wants to look at chicken scratch or try to discern something, especially if you have a 2 is actually a 7, or some type it's not legible to being able to see. And I'm very much about building relationships, and I think that it's one of the things, if you humanize anything that you do, I think it's very advantageous to you to have the third-party administrators. They're staffed by a small group of people. You get to know them. You ask about their day. How are things going? And sometimes you get a little bit further with a little bit of honey than a little bit of vinegar. Next. Probably this is kind of along that same line of following up with those third-party administrators for authorization. Not all companies will have the same date range, so you need to make sure that you allow your folks enough time of being able to get these authorizations. An expedited claim may take you there. Some insured payers we get things back within 48 hours or 24 hours. Others, it may take up to 5 to 10 business days. Probably the other thing is keep a copy of the authorizations. Whether you scan it in, you have the ability to obtain it, but that's probably one of your best things against getting a denial. Next. So as new agents emerge on the market, we felt the need that we needed to take the extra steps to make sure that our patients understood that their cost share, and in addition to simply getting paid for the medication and portion of our therapy. So one of the things we use, some of the support programs, whether it's on or off label for these high dollar medications, and then we will also, and this is in addition to doing like our own pre-certification process. We kind of screen those patients at the time of scheduling and work with our clinic nurses, our pharmacists. We've developed some work queues, and we also developed even a cycle 1, day 1 report that we try to find those folks that may have a higher out-of-pocket expense, to kind of help to make sure that we're going to ensure, 1, reimbursement, and then 2, also making sure that that patient can afford their copays. Next. This is a depiction of our high dollar process. It looks a little busy, I know, but kind of along the line, it runs kind of in 2 therapies. After we get that patient signed up for the reimbursement information through pharma, and it's sent to my reimbursement specialist, the information gets sent off, and the reimbursement specialists they go about their way, and they're actually going to get the authorization and pre-certification for that patient. But on the back end, my medication assistance folks are going to make sure that screen that patient, when that information comes back with the benefits investigation, they're going to see what their out-of-pocket expenses are. Have they hit their out-of-pocket max for the year, or do they still have $5,000 or $10,000 that they still have to meet? And those are the folks that we're going to try to make sure that they need resources of making their copays so they're not put on a payment plan at the end of the day. Next. one of the things, probably moving on to predetermination, we use our predetermination when dealing with off-label indications or new agents that come out on the market. And so it is probably, it's a method that at the James, it's an effective, traceable form that we have from kind of the start when they have that patient's therapy has been, yes, we're going to go forward with this therapy until that therapy's been approved through the payer. We kind of have a homegrown system that we've used since 2003, and actually we follow it on a monthly basis and report back to our hematology oncology P&T committee of kind of our successes and failures and things of where we're at in appeal, so that they can understand of what's, especially with off-label drug use, is there something that we need to address. Next. So these are kind of the important steps in predetermination, very similar in pre-certification, but think about this as probably a much more in-depth novel of the story that we're going to tell. So the reimbursement specialists are going to retrieve all of this information, put the information together, and they're going to tell the story. And they don't pull any punches with these stories, especially if patients have failed multiple lines of therapy. They're going to make sure that they humanize this patient's story to the utmost when they're sending this information, and then in the follow-up that happens for that patient. Next. So one of the things when you communicate with a predetermination, you need to be very, very clear to the folks on the other end, because payers call them different things. They may be medical review, case management, predetermination, but you need to make sure that you let them know this is for an off-label indication for this medication. It is an IV infusion in an outpatient oncology setting versus an outpatient pharmacy, because many times they will try to transfer you over to ICLIO or CVS Caremark, and you're like, whoa, hold on. Unless the process actually does need to be approved, CVS Caremark has some of the authorizations that they do, but each payer is going to be different, but knowing your pathway of what each payer, where you're going to go for each payer. Is it an online portal? But most of the predeterminations, you actually have to submit a packet of information of whether it's H&P, peer-reviewed literature, compendia support, previous therapies, a letter of medical necessity, rationale for therapy. Those are things that we do. And there again, I probably have this in a couple different places. Keep copies of all authorizations granted. If you don't take anything else away from today, make sure you keep copies of all of the authorizations that are granted. Next. So one of the things this is probably what a lot of people want to make sure that they're going to do is getting paid for your IO agents and your other high dollar medications, just because they add up pretty quickly. Next. One of the things with anytime that you're working with infused medications, you need to be well equipped to handle denials. Some of the common reasons for denials, and probably the number one at the top, is your lack of pre-certification or authorization. That's your number one controllable facet in probably payment for agents. If you have authorization and you have a copy of that authorization, you should be able to get paid for that therapy. Not far behind is medical necessity, experimental, investigational. Another one that they will acquire additional information. Basically, they're kind of fishing. The payer is fishing for places of either to substantiate therapy, prove that the patient got therapy, or deny you therapy. So there again, think about that performance status. We want to make sure that that information is getting sent. Non-covered services, so the medication's not covered on the plan benefit. Out-of-network providers, timely filing, that's another avoidable aspect, but if you have more than you have enough people, that's a problem. multiple diagnosis codings for disease states and metastasis, sometimes not having the correct code for medications. So you have the right J code, but you don't have the right MIM code. So there again, having that relationship with MIM is super important. And then the number of units that have been billed to a payer. So there again, if your authorization are for 90 milligrams of pembrolizumab and you're billing 100 milligrams of pembrolizumab, you're going to get a denial, and they want to know why you gave the other 10 milligrams. Next. Probably making sure that you get denials routed to you properly is probably an internal feat. I think there again, creating relationships in both internal and external are very important. We have worked with our IT department to create various work queues and notification processes so that we can have things routed to us so we can get it in a timely fashion. And that QA of actually working with, I meet with both our federal and commercial billing directors on a monthly basis, that we elevate issues that aren't typically medical necessity, but things that some of their teams can take care of on probably a little bit easier basis than what my team does. Appropriateness of resources, making sure that you stick to strict appeal timelines. Many of the payers are decreasing from, some of them had been a year, now they kind of shrunk down to 120 days, some are now 60 days. So making sure that you're aware of those timelines for their payers for appeals. The number of denials and appeals per person is also very important. We also, for your training and experience for those folks that are doing your appeals, are super important as well. Next. So when you review your payer information, probably one of the other big things that you can do, if you're able to reflect or do a redetermination for your local coverage decision or national coverage decision, or if there's something specific within a payer policy that you feel that you have evidence that you can make a change, I think it's always good to look at that information and see, is there anything that you can change, but looking, especially if it's outside of the information that's there. If we know it's going to be outside the LCD or NCD, we know we need to get the patient an ABN. But then also, too, we can educate. We know to expect that, especially if therapy goes forward. We know to expect it, and we can write that appeal that's coming on the back end. There again, this is coming up, making sure you have the copy of your authorization, making sure you have the representatives, patients of their name listed, and the documentation that is there. So it's one of the things that the reimbursement is always linked to the quality of the bill. So what's going out, if you have a good quality in your bill going out, so if it doesn't reflect, are there any errors from your EMR, making sure that you work closely with your IT team and your informatics teams to making sure that if there was a Metaspan upload for those information on the medications, that there are no discrepancies going from when the bill drops to when the bill goes out. And there again, with meeting with your coders. Next. Trying to make sure with peer-to-peer interactions, I think this is probably one of the best defenses that we have of trying to get a like-to-like, so having an oncologist or a hematologist speak with a like-minded professional versus having them speak with a podiatrist, and being able to effectively communicate that rationale of therapy. It is probably one of our best defenses. Now, if we're having to do it for every single therapy that comes across, absolutely becomes very exhausting for our providers. But I think on specifically on off-label cases, we have been very successful in having those conversations get over and having the denials overturned with those peer-to-peer conversations. Monitoring for trends, I kind of talked about this earlier, but looking for repetitive reasons that require either our payer or billing or even our provider education. Are we not putting in clinical information or proper documentation in the notes as far as we are using nivolumab for this because of this rationale, and we have providers that even will list the study that it is linked to for that. But as far as if it's not documented, it didn't happen. And I think the other thing too is you need to hold your payers accountable for, if they're coming back with, you have had a rash of lack of pre-certification denials and you have the whole list of them, there's something broken in the process. Is the third-party administrator not getting that information to the parent company in a timely fashion? You need to hold them accountable. And I don't care if you're the smallest organization or a very large organization. If you follow that trend, you have a contract in place for a reason. Next. And then outdated payer policies. Some of the payers are not very good at updating policies, so for new indications that come out, they still are listed as medically, not medically necessary. And so the folks that process the bill, that they'll say, well, it doesn't say that it's covered here. Well, this is what the FDA has approved. Well, what the FDA approved and what said payer approved sometimes doesn't always ask, don't always match. So, trying to leverage the available information, whether it's the FDA or new peer-reviewed literature, to making the change with that, getting in front of that payer is super important. Next. So, as I said before, the payer policies do lack. We always have to ask permission, especially we always for every single new high-dollar medication in advance. And sometimes we ask for that predetermination. I've had, and I hate to say that I'm not going to name the payer that did this, but they had it was 6 weeks after a new drug had been approved, and they still were saying it was not a payer-approved medication, regardless if it was the FDA-approved medication. And they wouldn't look at the medication until it had been reviewed by the payer. So it actually involved a lot of, I'm sure, some gesticulating and actually some lobbyists getting involved, and we finally were able to get the patient the therapy that they needed, but advocating for that patient is probably the best thing that we can do. New payer authorizations, lots of times changes are not, that sometimes aren't communicated well. It's up to you as the provider to make sure that you're looking at those updates either on a quarterly or monthly fashion. So most payers will broadcast at least a quarter before when they're going to make any changes. It's up to you to make sure that you know that, because sometimes it may not be communicated. Maybe if your team member missed a meeting or you missed the meeting and you missed that, Tecentriq is now going to be authorized for this new payer. You need to make sure that you know that, and you have a mechanism to make sure that you hit all of those authorizations, because retro-authorization it is obsolete any longer. It's very, very hard to ask somebody to go back and authorize something when the therapy's already occurred. Next. One of the biggest challenges, I think, with new agents that come out are the codings that go along with it. When you have an unclassified drug or biologic code, either if you're in the hospital outpatient setting, the C9399 or the J999 setting in your physician and clinic setting, you're going to end up, on your claim, you're going to need your NDC number, your quantity of drug administered, as well as the date of administration. And sometimes that crosswalk works really well, and then other times it doesn't. I actually get on a monthly basis C9399 authorization, and I will work each one of those claims to make sure that we get paid a sufficient amount. Now the other is too that when CMS, before you get a permanent J code, they provide a temporary code. That sometimes puts a kind of the fly in the ointment for some payers, because they don't recognize it. They either recognize that unclassified code or the permanent J code, and so end up dealing with lots of denials that we've had to work out on an individual basis, saying, yes, this temporary code does equal nivolumab. This temporary code does equal pembrolizumab. So it's not linked to just IO agents. It's actually linked to other agents as well. So it's a place that you can look for underpayment or denials that are easy to rectify. Next. With probably successfully working with payers of having dedicated staff that perform your pre-cert, predetermination, and denials are paramount. I mean, they develop relationships with our payers, with our medical review folks. They're some of the, from some of the medical directors know my nurses from the third-party administrator, and they will call. They'll submit something, and they will call them and say, Susan, I need you to submit X, Y, and Z. Are you, is there anything else in this case that you can give me? Any previous therapies, things that they will sometimes lead, or we've had them even say, this is what the dosage I can approve. And so it's interesting just to kind of see on how that relationship has developed. Always reviewing those clinical policy bulletins, newsletters, regular review your online payer policies. I also sit with in each month each quarter, I meet with our payers at our operations meetings. So they talk about, they will talk about, the AR, they talk about other things that are not just drug related, but kind of the hospital as a whole. And many times there's trends that develop that are not just in drugs, but we see across the board. So in person, I'm able to meet quarterly with those folks and elevate issues and build those relationships. So when we have kind of a 911 emergency of getting something authorized quickly, at least I have that relationship developed with those folks. So the other is too, when you have new research and new clinical practice and reimbursement that comes out, we're able to kind of get that information to the right folks that provides that clinical evidence to alter those clinical policies. I will tell you with the commercial payers, it's really tough to do. CMS actually is its peer-reviewed literature. They are much more open to looking at that. And the other piece is actually our account reimbursement representatives. We've been able to leverage with them, because if we're not able to gain some ground, and I kind of talked about frequency edits, we actually were asking, how do you want us to deal this? Do you want us to do a predetermination? Do you want us to do, do we need to give you other additional information based on this patient's weight? And actually, when we weren't getting answers, we, leveraged some of the relationships that we had with our pharmaceutical representatives, because if they're starting to hear that information all the way around, it actually might help to benefit us. Next, I believe. And just kind of want to end on kind of future considerations. I think we're in an exciting time that these are wonderful therapies that we see with the IO therapies, that they're new lines of therapies, new tumor types, and I think that we have to make sure that we keep up with the escalating evidence and getting that information to our payers as well as CMS. And I think that we're starting to see that utilizations right now in clinical trials with the PD-1 inhibitors with other agents, either oral or infused. And, then what are probably then, of that being said, what are the financial implications for those agents becoming first-line therapy for both patients, for organizations, and for payers? And so what type of pushback are we going to get? So it should be very interesting of doing that. So I know I went over a little bit for what I was slotted to do, but if there's any questions, I'd be happy to entertain those. Thank you.
Great. Thank you so much, Sarah. That is a wealth of information. And a lot of the questions coming in are actually related to wondering if these slides will be available after the webinar. And yes, they will be available as well. So they will be on our website. And we will email the link to the archived broadcast as well as the slides to download. So we will provide that. So again, Sarah, wonderful. Everyone's very appreciative of your wonderful presentation. So there have been a couple questions that have come in. So just one of them was noticing that your data or your presentation didn't include ipilimumab. So just kind of wondering where that kind of fits in at the Jane.
We do use ipilimumab in combination, actually, with pembrolizumab, with nivolumab. We have some clinical trials. We treat it as a high-dollar med, so it gets the same scrutiny actually as pembrolizumab, nivolumab, Tecentriq. It's kind of right along there. You know, probably the biggest with the adjuvant therapies. We have a couple clinical trials here that treat both stage 3 and 4. So that's an interesting. We can either, you know, how we handle that. So we follow that high-dollar process that I talked about, that we will look at that patient very closely. We will get the PAP information signed. We will do a benefits investigation, get authorization, and then you know, look at that patient for any type of copay assistance. Now we do, BMS has an adjuvant program, so we will take advantage of that if the patient is, if there's either a denial or if that patient is in, they have that grade 3, you know, clinical markers. So hopefully that helps. But yeah, ipilimumab is right in there. It's one of our high-dollar agents.
Great, thank you. All right, and another question. So how do you ensure that the denials are being sent to your department for appeal? And are you seeing many IO denials?
So ensuring that they come to us, it's a lot of work, or it has been, I should say. It's a labor of love that by meeting with both our federal and when our bills come in, the first line of defense in most organizations is they come to the rev cycle folks. So the revenue cycle folks are going to look through and see if there's anything that it needs to, and where it gets kind of sent to various queues. Ours is actually a child queue of a larger queue, and so we've done a lot of education with those frontline folks, and so if it comes back for medical necessity, authorization, experimental investigational, that they want to route it correctly to our queue. I find some of the ones that haven't been, and then we work with their managers to make sure that that any re-education that needs to happen does happen. I wish I could say I wasn't seeing denials for IO agents. We are. I did like 4 appeals yesterday on nivolumab. It's basically of showing they were ones that we had predetermination for, basically resending that packet of information with the peer-reviewed literature, with clinical evidence, you know, and kind of showing those outcomes. But it is sometimes a lesson in futility of like, yes, we're being successful with that. So we've actually had more, initially we had more troubles around coding. So with of that J99 to the temporary code to the permanent J code, we had more of those initially before medical necessity. And now they're starting to get a little picky. They want to have some other information. And so we are proving medical necessity for these agents.
Great. All right, thank you. All right, I think we have time for one more question. So for indications that are denied for pre-certification or predetermination, is it better to appeal the denial or go and ask for a free drug from the pharmaceutical companies?
I'm one of the advocates I think it's always better to try to appeal it first. It's much better, I think, for the patient, for the organization, for kind of your workflow process to exhaust those lines. It's one of the reasons we do enroll those patients into the PAP programs ahead of time, because then if we have denials, we can kind of fall back and say, you know, we're having these issues. I have some pretty savvy folks that they will exhaust the therapies that are there, but I think that, you know, our patients pay premiums for the insurance that they are being provided with, and I think we need to be good stewards for the resources that the pharmaceutical companies that are offering.
Great. All right, well, wonderful. Thank you so much, Sarah. And I just want to say again, thank you for this wonderful presentation, and to our audience today also for attending and participating. So again, both the webinar archive and these slides will be available on our website. That's accc-iclio.org. We'll get that up shortly. And you'll also, again, receive an email with the link as well. And also, don't forget to save the date. So our upcoming ICLIO conference is going to be held September 30th in Philadelphia. So register today, and you will hear wonderful presentations, again, that really hone in on the real-world applications and the real issues associated with IO agents. So we're really looking forward to that. And I hope that everyone has a great rest of the week. Thank you.
Thank you.